David, we've one quick thing to do before we dive in. Do you want to share your screen there and spin the wheel and pick our winner of the Aura ring? There we
There we
go.
go. There we go.
Ooh, it's a close one. Bijal Patel is the winner of the Aura Ring
Wonderful.
and the subscription. Oh, congratulations.
That's Ellie. Ellie. Very good. As usual, guys, we have another little giveaway to do as well. So on today, this week, essentially, if you share this on your story and you tag Kmart Fitness, if you tag either myself, Sam, or David, and if you want to tag Amar as well, what we'll do is we're going to enter you into a draw where you can win a free comprehensive blood work and a consultation with Kmart or with Amar. So I think it's definitely one worth entering. Okay, Amar, let's start to dive into our topic of conversation. I'd love a little bit of an introduction about yourself.
Yeah, for sure. Yeah, thanks for having me. This is great. I'm Amar Shere. I am a cardiologist by profession. I practice non-invasive cardiology, so tend to kind of focus on prevention. And I am, work out of Hackensack University Medical Center. So I have a practice in New Jersey. I've been practicing for about 3, 4 years in specific cardiology, but also have background in heart failure, nutrition, integrative medicine. And I got started with KMAC Fitness about 3 years ago with Kunal as my coach. And, I think I started, KMAC because I felt like I was a bad cardiologist to begin with. I wasn't following the advice that I give my patients. And so I kind of got more involved in how lifestyle medicine kind of works, prevention in South Asians. So I'm really passionate about heart disease risk reduction in South Asians. And I've seen the tremendous effect that a fitness program like this has on one's health. And that's why we kind of am launching this kind of new K-Med program to kind of integrate this kind of health aspect to it. But yeah, super. It's been an amazing journey with K-Mac Fitness, and I'm still coaching. I'm still a current client now. Max is my coach. He's keeping me, in line and on track with my goals. But yeah.
Awesome, awesome. So you're currently in a muscle building phase at the moment. Is that correct?
Yes.
So
Yeah.
you're going through this period of actually like ramping up and pushing up your calories.
Yeah, we're getting there slowly. So I think we're still kind of at a slow calorie, deficit and then kind of working our way up. So I'm definitely going harder in the gym. So like heavier weights, definitely progressive overloading more. And then we're gonna slowly kind of ramp up calories and stuff. But yeah, I've with K-Mac Fitness, I've done 2 photo shoots, which I did a year apart, which I don't recommend, but it was definitely a cool like learning experience and got into the best shape of my life and yeah, just kind of seeking new goals now.
Awesome. Well, you can share your screen there and let's dive in. This is honestly,
All right.
this is a topic I absolutely adore. I love like all things cardiovascular disease. It definitely would have been, if things had been different, I definitely would have went down the realm of like cardiology. The only problem is it's just a really long time, isn't it? Like
It is,
minimum.
yeah, it's like 12 years of training. And I've done like 15 years total because I did additional training in heart failure and masters and stuff. So yeah, definitely a long, long time. But yeah, it's definitely very rewarding to me. And the reason I got into it is because heart disease is the number 1 killer in the world. Leading cause of death, especially in South Asians. We definitely have a higher risk of it. And for me, it's like, how do I make an impact directly? And so with cardiology, there's so many things that you can do about 80. We'll kind of get into like there's so much modifiable risk factors. 80% is like preventable. And so for me to be able to educate my patients on like, hey, how do we actually reduce your risk is super rewarding. And so that's one of the reasons why I got into it. So yeah, so we'll kind of dive into like more heart disease. So we'll kind of talk about an introduction of like what heart disease is, how heart disease happens, the risk factors, why South Asians are kind of proportionally higher risk of developing heart disease, things that we can do about it. And I kind of want this to be less of a like a lecture. So like feel free to drop in your questions in the chat. If you have any, and we can kind of have a discussion, and then we'll kind of get into the actual like K-Meds program and why we actually developed it and how it could be beneficial for you. So in general, when we talk about heart disease, I kind of like to group them in three different buckets. So there's so many different aspects of the heart. And so there's a electrical system of the heart where you have electrical signals that actually help the muscle contract throughout the cardiovascular system. And so you can kind of have disorders and abnormalities in that. And then the second part of cardiovascular disease is, vascular issues. So that is, actually issues with the coronary arteries. So when you have blockages, narrowing of the vessels due to cholesterol and plaque buildup, that's kind of, when we think about heart disease, mostly we kind of think about this. We think about the vascular system. And then the last kind of bucket is kind of your valves. So we have valves, which are kind of like doorways of the heart where blood flows in and out of. And then we have the actual structure of the heart. And so when that structure weakens, there's a lot of things that can weaken the heart muscle that can lead to heart failure. And a lot of these are interconnected, and so I wouldn't take it, one thing at a time, one system, but definitely, the coronary arteries can affect the structure and the pumping function of the heart.
Cool. Okay, so essentially it's the case that cardiovascular disease is an umbrella term for a whole bunch of diseases, whether it's like a myocardial infarction or coronary heart disease. Okay, so cardiovascular disease is that umbrella term essentially.
Exactly, yeah. And myocardial infarction is basically a heart attack. So that's just a scientific term for a heart attack. But a lot of these are kind of interconnected. And so when we think about heart disease, and we think about heart attacks and arteries, we kind of want to look at the endothelium. So the endothelium is basically your blood vessel and the lining of your blood vessel. And then this is really the crux of heart disease, right? I like to think of the endothelium as like the life jacket, of the heart and your vessels. As you can see on the left side, it's really nice and open. There's no narrowing, and a lot of this is contributed by like things like nitric oxide and different factors that keep it open. And then on the right side is basically your endothelium filled with gunk and cholesterol and inflammation and things like that. This is what we want to try to avoid because this is what actually causes narrowing of the arteries and eventually can lead to a heart attack. And so, again, this is a good picture of a normal artery, normal blood flow. So blood flow, typically in an artery, you have blood flow going away from the heart where you're getting a lot of nutrients and oxygen delivered to essential organ systems, your muscles and kidneys and things like that. But when they develop atherosclerotic plaque through cholesterol, this can narrow, and then this can kind of interrupt the blood flow, which causes a heart attack. And so the whole, purpose of prevention really is try to prevent you from getting to that point where your arteries are very narrowed and that leads to a heart attack. Again, I mentioned heart disease is the leading cause of death, 17 million deaths annually. And specifically South Asians, are disproportionately impacted, and they tend to have a greater burden. So, we comprise 25% of the population, and we actually suffer over 50% of the cardiovascular deaths. And, it's definitely alarming the rates of heart disease. And so, in general, what do you think are some of the risk factors that you can think of for heart disease? Anyone can kind of chime in.
Smoking.
Smoking, okay, good.
Yeah, well, you mentioned atherosclerosis, so cholesterol is going to be one of them.
Cholesterol, yep.
Nobody knows how to say that word, Sam. Don't worry.
Yeah, I was going to say I'm stumbling over athero. I can't even say it again.
Atherosclerosis, yeah. Are there other risk factors that you can think of?
Diet in general.
Diet, okay, yep. Poor diet.
High blood pressure.
high blood pressure. Good. Yeah, I'm glad you said that because a lot of people don't think high blood pressure as a risk factor for heart disease. They think of it maybe as like a heart risk factor for like stroke and kidney disease, but definitely high blood pressure definitely is a risk factor. So yeah, good. So basically, the way I like to think about risk factors is in, again, two different buckets. So things that are modifiable and non-modifiable. So, non-modifiable are things that like you just don't have control over. These are the cards that you're dealt with when you're born, your genes, unfortunately, your age, and your gender. And then we have modifiable risk factors, things like you guys mentioned, like smoking, high blood pressure, high cholesterol, physical activity, diabetes. And so, majority of heart disease is actually caused by these modifiable risk factors, which can be prevented. And so that's kind of, the way I like to kind of look at risk factors. So we have the traditional risk factors that I just mentioned, and then other several lifestyle choices that put people at harm's way. So being overweight, obese, and I'll kind of talk about how that's even more important in South Asians because we have a separate criteria for BMI and obesity cutoff. Eating an unhealthy diet. I'll kind of get into more of like what's an unhealthy diet, physical inactivity, alcohol, and actually we have these things that we call risk enhancing factors. So kidney disease, inflammatory diseases like rheumatoid arthritis, hypothyroidism, metabolic syndrome, and just being South Asian actually puts you at a risk. So that's like a risk enhancing factor, just being South Asian. So that's kind of important to kind of know. And again, we're 2 to 4 times likely than other ethnic groups to develop heart disease. 50% of heart attacks occur under the age of 50. 25% occur under the age of 40. So these are definitely alarming. I've had patients that are South Asians and they're like 36, 37-year old and they come in with heart attacks. And it's scary, especially for me, like being around that age in our 30s and 40s, it's like that could be me, right? So it's definitely alarming these rates. And not only do we tend to develop heart disease at a younger age, but it tends to be more severe, so more malignant. So we develop more blockages in multiple arteries that eventually sometimes you need bypass surgery that can't be fixed with a stent. So they tend to be more severe and resulting in death at a younger age. And then, about 44% of normal weight South Asians, so these are not even obese, had actually higher abnormalities compared to other ethnic groups. We have 6 times likely of having diabetes. And then we'll kind of talk about, one of the main reasons is South Asians have a high prevalence of abdominal obesity. So I'll kind of go into that a little bit more in terms of like, the visceral fat and how that kind of contributes to this disease risk. And then also lifestyle. So there's so much of heart disease in South Asian that we don't know yet. It's still kind of, research still needs to be done. But, again, I think there's multiple genetic factors, certain lifestyle factors as well, lower levels of physical activity in general, unhealthy patterns, high level of psychosocial stress. I think in general, we tend to have a lot of pressure and stress that may lead to this. Any questions so far? All right. So getting kind of back to the visceral fat. So the reason why I think a lot of South Asians have this higher risk of metabolic disease is higher levels of visceral fat accumulation, even at lower BMIs. And this is a genetic factor. They could be also dietary, environmental, but we tend to, I don't know if some of the coaches or you guys have heard of the term TOFI. So basically, South Asians are thin on the outside and obese on the inside. And so basically, we tend to look okay from the outside, but we tend to really have a high level of visceral fat that's hidden. So visceral fat is basically the amount of fat that is underneath your subcutaneous fat, which surrounds your organ systems. So your liver, and this is actually linked to all these risk factors that we talked about. So increased LDL, insulin resistance, dyslipidemia. It actually leads to the stiffness of that artery wall that I showed, and metabolic disease in general. And so what's interesting, and so the reason why I say this, that, hey, we have a high genetic risk, okay? That's something that we can't change. Like we talked about, these are non-modifiable, right? These are just the cards that we dealt with. But there's actually a really interesting study, and I love this study because it actually looks at how genetics actually play a role when you adapt lifestyle into it, right? So while genetics play a role, lifestyle factors actually significantly change and affect the gene expression. So there's a study that looked at different genetic risks, low, intermediate, high. And so those that were at the highest, risk genetically actually benefited the most from lifestyle, changes. So even if you have a very, very high genetic profile, and we'll kind of talk about the labs and how to detect that, whether you are genetically predisposed to high heart disease, by just implementing lifestyle factors, resistance training, eating correctly, reducing your stress, optimizing your sleep, you can actually benefit the most. And that level actually is similar to intermediate or low genetic risk. So this is really, really fascinating. I think this, especially, within the South Asian community, I think this is really important to kind of know that, hey, you have a genetic risk, but actually implementing a training program, a plan, lifestyle changes can actually, really help. And then, so again, what can we do about it, right? So I really like to use this example of the American Heart Association's Life Essential 8. And it basically, looks at different lifestyle factors that affect and benefit you in terms of heart health. So eating healthy, staying active, getting enough sleep, not smoking, maintaining a healthy weight, controlling your cholesterol, managing blood sugar, keeping blood pressure in healthy range. So we definitely, like, this is what I do in my practice, is really try to focus on these life essentials 8 and ensure that we're kind of taking a holistic approach to prevention and holistic approach to actually reducing your overall risk when it comes to lifestyle.
I think it would be a good idea if we just double back on that slide there for us to
Yeah.
go through and just give like the biggest levers to pull to actually go about doing this. So let's say, for example, the life essential 8s. You could think about like one big behavior that you'd focus on in order to improve on all of these areas.
I think the biggest thing, I mean, if there's one thing that I tell my patient if they were to start, is just moving more. There's so many people that are just not exercising. We're just physically inactive, right? And so I would just say, if you were to start, if you were to choose any of these, I would just say to move more. Whether it's getting more steps in or resistance training, like slowly progressing to that, I would say that, because that will actually, help in so many ways. There's so many benefits of just moving more, and walking a certain number of steps reduces your risk of high blood pressure, can help with weight management, blood sugar control. So I would definitely say exercise. And when it comes to exercise, there's actually particular recommendations from the American Heart Association. So you want to aim for at least 150 minutes of moderate aerobic exercise, right, to really get the benefit. So strength training is great, but also I think adding a little bit more aerobic exercise in that sense may actually be beneficial too. But again, I always say start where you are. I think, it's really daunting when I tell patients like, hey, I want you to exercise 150 minutes a day, a week, and they're not even getting like 10 minutes, right? So I think it's, taking it a day at a time, slowly, building these habits, and then adding to it. I think once you get more confident in adding more steps, doing more at the gym, lifting more, heavier, things like that, I think that will help you in the long run, and you'll actually feel better. I think I find that my patients actually come back to me and be like, hey, I know you told me to work out twice a day or twice a week or 3 times a week, but I'm actually doing it every day because I just feel better. So that kind of, I think, just leads to a cascade of positive behaviors along the line. So that's what I say.
Yeah, I think like I would very much agree. If there's like one thing that you could do to improve your health, it's just it doesn't need to even be resistance training around and just be physically
Yeah,
active as a whole. Get your heart rate up and like really
exactly.
bias towards resistance training and getting stronger. And obviously there is unique benefits there, but as a whole, just get some good solid physical activity in.
For sure. Yeah. And we actually have a lot of data on even just step count, right? And I'll kind of go, I have a study that shows that you dramatically reduce your risk of heart disease just by getting 9 to 10,000 steps. Even 7 to 8,000 steps a day is really, really beneficial. So if you can aim for that, you're already, doing the best that you can for your heart health and already ahead of people that are very physically inactive. So, yeah, I agree. I think just moving more and finding what you like. I think when it comes to exercise, I think it's helpful to kind of say like, okay, do cardio or strength training. But I think also if you supplement things that you enjoy doing, like even it's like playing tennis or I'm a dancer, so I love dancing. So I'll take like a dance class once a week, and that's kind of my like movement and for the day. And so I think you're more likely to stick to it if you enjoy it. And it's not like a burden, like, oh my God, I have to get 10,000 steps in today. So it's just like it's doing that.
No, 100%. I think the only thing I'd add there as well is you mentioned 150 minutes can be a little bit daunting, but we always see the biggest improvements in health from just going from simply not doing much at all to just doing a little bit, right? That's where that biggest improvement actually lies. And then
Mhm.
it slowly kind of tapers off a little bit after that.
Yeah,
So just simply kind of taking the first steps, the biggest thing. And moderate intensity exercise will be kind of relative to the individual starting point as well. For some
right.
people, that may be so. For you, for example, who does a lot of dancing, that might be relatively high intensity for someone else, right? For someone, moderate intensity might just be going out for a short walk.
Right. Yeah, and there's ways, there's ways to kind of measure moderate. So, if we can kind of get into like the cardio zones. If you have an Apple Watch, moderate intensity is being in zone two, like 60 to 80% of your max heart rate. So we can actually kind of, I kind of guide my patients like, hey, this is, once you get to that point, these are the types of exercises that I want you to do that actually get your heart rate going to this particular heart rate in this zone. I think that could be helpful too. But I think, like you said, it's just a matter of starting. I think it's just starting, and then once you get, past that hurdle of just starting and moving, then you can just kind of build the momentum. Yeah. So again, these are just like different things to do to move more. So aerobic exercise, resistance training. Which we know it really helps build muscle strength and improve metabolism. Flexibility exercises, improve joint range of motion, may reduce risk of injury. Balance stability training to reduce risk of fall. And this is why, when it comes to moving more, this is another thing that I tell some of my older patients actually is to incorporate resistance training. And, I think resistance training is incredibly important, especially in the older population, because
trying to figure out my schedule for it. It might be more of a little behavioral.
oh, sorry. Especially in the older population, because as we age, we actually lose muscle mass. Like after the age of 35, you lose about 1 to 1.5% of your muscle mass per year. And that exponentially, increases after the age of 60 and 80. And we have ways to combat this, right? So eating a high protein diet, resistance training 2 to 3 times a week can actually, help reduce that muscle mass loss and prevent sarcopenia and all these risk and fall risk, especially in older patients. In my practice, I probably get, I would say, 50% of consults of just a patient falling and being injured, and we kind of have to figure out as a cardiologist. I kind of figure out whether there's a cardiovascular component to it, whether they had an electrical problem with their heart or what's going on that caused them to fall. And a lot of the time, these patients are just so weak. They're not resistance training, they've lost their muscle mass, and they're more prone to risk and falls. And so I think to combat that as we get older, I think resistance training would be like superior to as a form of movement. And again, I'm sure K-Mac, training programs incorporates a lot of this. I think resistance training can be performed in many ways. You don't need fancy equipment in gyms. I think a lot of when I tell my patients like I need you to strength train and do resistance training, they kind of have these barriers. I don't have a gym access or I don't have particular weights. But even body weight exercises using resistant bands, free weights can all give you the same kind of benefit. So it's just a matter of actually consistently doing this at least 2 to 3 times a week, focusing on different muscle groups. And it has a huge impact in all these risk factors that we talked about, especially the traditional kind of risk factors. So yeah, this is just kind of some data that show that adults who participate in resistance training actually have a 15% lower risk of all-cause mortality, so like risk of death from any cause, and 17% lower risk of heart disease when compared to adults that don't do any resistance training. And this study actually I found really interesting because I was also very curious about this. I'm like, is my like strength training, uh, you know, I guess my outcome, from strength training, is it any different than any other group? Am I set up because of my genes? Am I set up to build muscle like I want to, or get that goal? So they did a study looking at muscle protein synthesis in response to resistance training in South Asians and white European men. And in response to resistance training, there were no differences in muscle mass, lower body strength, or even insulin resistance. So South Asians actually are able to mount a very similar, protein synthesis, anabolic response to resistance training, and similar increases in muscle mass and strength. So they actually did a study on this. I think that this was pretty fascinating to kind of see, like even in response to 12 weeks of resistance training, that we actually mount a very similar effect, and it's not really affected by our genetics. And strength training again was also more effective at reducing HbA1c levels. So this is the marker for diabetes. And so basically important finding was that the body composition change was independently associated with a reduction. And so just strength training alone was effective in really reducing diabetes risk hugely. And then we kind of touched on this again, just kind of the step count, but getting 9 to 10,000 steps really lower the risk of developing heart disease by 21%. But we also see benefits at lower step count. So like even 7 to 8%, 7 to 8,000 steps a day can be really helpful. And then kind of switching gears to more nutrition. Any questions about the exercise part or resistance training?
I'm correct in saying, like, as amazing as exercise and resistance training is, even like weight loss as well, like they don't necessarily reduce LDL cholesterol.
They not directly. I think it just improves the lipid profile itself overall. Exercise is known to increase your HDL, which is kind of your good cholesterol. So I definitely see that a lot more, and that's been researched. But I think overall, I think it just improves your whole metabolic profile in general.
So it just kind of reduces like ApoB containing lipoproteins as a whole. So it helps with the dyslipidemia side of things.
Exactly. Yeah. And just kind of overall reduces, that in turn reduces risk of metabolic disease and syndromes. But yeah, I do see exercise actually have a benefit effect on HDL, which is kind of the protective type of cholesterol. Yeah. But I think that's a good segue into like, hey, how do we actually manage our LDL levels and lower this cholesterol? And so I think diet really plays an important role. And so we have these recommendations from the American Heart Association and nutrition guidelines that actually say, a diet emphasizing intake in vegetables, fruits, legumes, nuts is actually recommended. It's a class 1 indication, and replacing saturated fat. A lot of the cholesterol that we have in our body is made by the liver, but it's also the extra is contributed by diet. And so there's a strong correlation between your saturated fat intake and your LDL levels. So the more saturated fat you consume in your diet, things like red meats, processed foods, things like that, certain types of oils, actually contribute to increase in LDL. And so we kind of want to replace that with dietary monounsaturated fats, polyunsaturated fats, things like olive oil, avocado oils, and kind of just diet is more in line with a Mediterranean kind of diet.
It's
And
like
minimize those foods.
it's like fascinating. It's incredible how well this relationship is established to the point where we have like a calculation, like
Yeah.
Key's equation to predict an individual's change in cholesterol levels based on their polyunsaturated fat to saturated fat in the diet.
Yeah, no, absolutely. Yeah. And I do this in my practice too. I kind of, use these data points and these numbers to actually calculate a risk of someone's risk of having a heart attack. And I actually did that myself too. And I'll share that I actually did like a before and after my transformation, and the results were insane. Like just in terms of like just changing certain metrics, changing biomarker levels, how dramatically your risk reduces. So yeah, this is just another kind of slide on diet, and we have like different dietary patterns, like the DASH diet. So if someone is having high blood pressure, this is kind of an approach to limit your salt intake to 1,500 milligrams a day, and really have a diet rich in potassium, fruits and vegetables, to really kind of help with that. And I say this because I think there's so much, and you guys can chime in. There's so much noise about nutrition on the online world, in the wellness world, that it can get really, really daunting and confusing. And I don't think any diet or one food is going to cause disease, right? So if you like to, eat meat, or if you like to indulge on, a particular type of food, I don't think that's going to cause a disease. I think overall, I'd like to take a bigger picture and look at the overall dietary pattern of like during the week, how much fruits and vegetables are you eating? Like, are you eating a well-balanced diet and not just eating red meat every single day? So, even though I'm vegan, and I've been vegan for 12 years, I've never recommended it to my patients. I always kind of recommend a plant-forward diet. I think, diets, obviously vegan diets are not for everyone. I think any diet can be unhealthy. Even a vegan diet can be unhealthy. Like if you just ate like French fries and Oreos, that's like a vegan diet, right? And that doesn't mean it's nutritious or healthy in any way. So you really have to take an individual personalized approach to this, and talk to people that understand this, and really look at their overall pattern. I think you have to take that in consideration, because especially when it comes to South Asian diets, I think it's hurtful, and to kind of say, hey, you should stop eating this because you enjoy it. And if you do that, I think that's a detriment to your kind of sustainability and long-term goals.
No, I like that a lot, to be honest. I think plant forward, especially when it comes to dietary fats, is a good way of going about things. In terms of you mentioned there can be a lot of kind of noise and things like that around specific foods. I think one of those that often comes up, especially around cholesterol, is eggs. What would be your thoughts personally in around that?
Yeah. So, I mean, eggs are, I think, fine, as long as, again, you're not eating like 12 eggs a day, because obviously there is a component of cholesterol to them. And I think it's individual, right? So if you already have high cholesterol, I would not consume those in a large amount. I think once in a while is okay. 2 to 3 eggs a day is fine. But again, you really have to kind of look at it from your lipid standpoint. Make sure you're getting your lipid levels checked, and ensuring that that's not affecting it. But yeah, again, I think I hate to kind of remove a whole food item or food group from someone's diet just because there's an article that says, oh my God, eating eggs causes high cholesterol and heart disease. And I don't do that to any of my patients, because I know that's harder to follow a diet if I do that. So it's just a matter of, limiting the content, and limiting the quantity, and ensuring that, hey, this is actually beneficial to your actual risk and lipid profile.
Yeah, like I'd fully back that as well. It's particularly, I think eggs is a great topic because you don't want to be restricting like people from eating absolutely everything. But it's also wrong to say that it's completely fine as a general heuristic because there is going to be individuals, like I know I've looked into this for quite a bit, where we have individuals who are going to be cholesterol hyperabsorbers versus individuals.
Yeah.
That's going to completely dictate what happens to their LDL in response to egg consumption. But
Right.
with that being said, essentially there is meta-analysis looking at this, and like on average cholesterol levels increases. So when we're giving advice as general heuristics, then it would be the case that they do generally increase. But that's really annoying as well because you don't want to be telling people to restrict foods in their diet.
Yeah, exactly. Yeah. And there's not much data on that. I think when you're going again, like when you're making a change to your diet, and initially, I think there's also like short-term implications and long-term implications. So if someone is staying on a particular diet that increases their cholesterol, you kind of have to, look at the quantity of the increase and see, how long this is going on for. And if it is going for a long time and they already have a high risk profile, then you have to address it, with medications or, diet, things like that. But, there's not much really data on the long-term implications of, but we do know that in general, certain diets, such as ketogenic diets, very low carb diets, can increase your risk of heart disease, for sure. But I think it has to, you kind of have to have an overall picture of that person's risk profile, their numbers, and all that stuff to really make a judgment on that.
Yeah, 100%. Like we've seen
Um,
when you give people like a plant keto score versus an animal keto score, and it's nearly universal.
yeah.
By animal-based ketogenic score increases risk, while plant is neutral, if not like can be beneficial.
It's neutral. Yeah, and it's actually very fascinating. That is a topic that I love because there's actually studies that looked at why, plant-based proteins are actually better than animal-based proteins. And it actually has to do with your gut health. And there's actually a molecule there's a lot of research on this. There's a molecule called TMAO, trimethylamino oxide. And this is a molecule that generally is produced by animal products, animal protein. And this, if you have high levels of this TMAO, that actually causes more atherosclerosis and plaque buildup. And so I think that's kind of a difference. But there's like a whole research on how it affects your gut microbiome and gut health, and then just in general. But yeah, I think in general, I always recommend just like plant forward diets just because overall it kind of improves so many different factors in terms of your metabolism, your lipid levels, glucose, and weight in general. So kind of getting into knowing your numbers, right? So I think knowing your numbers and health metrics is it's vital to management and prevention. I think knowing your numbers early on can really enable early detection of risk factors, and really give you a personalized health management of like, hey, how can we tailor this approach to your particular needs? And really, knowing your numbers allows you and your healthcare provider to monitor your progress, and more of a personalized approach. So when we talk about numbers, what numbers are we talking about? Blood pressure, like we mentioned, high blood pressure is a major risk factor. Regular monitoring can detect hypertension early on. Blood sugar levels are very important to know. A1C levels can indicate prediabetes or diabetes, which are both risk factors for heart disease. And early detection allows for lifestyle change. And then cholesterol. So I'm curious to see what have you guys heard about cholesterol, and have you heard about the different types of cholesterol and how it contributes?
Go for it. Anyone jumping in?
I'm happy to. Essentially, it's the most well-established relationship we have with cardiovascular disease. The relationship is like so beautifully linear that it tracks like not only the duration of exposure, so how long we've had LDL cholesterol, but also
Mhm.
how high it is. There's been just the research on that is absolutely incredible. Like,
Yeah, no, absolutely. So there's traditional cholesterol that we talked about. So basically, cholesterol is essential to the function of our bodies, right? It contributes to a lot of different mechanisms. But diet contributes to the excess cholesterol circulation. So most of it is made in the liver, extra comes from diet. And so when we talk about LDL, which is what we call the bad cholesterol, the reason why we call it the bad cholesterol is because it builds up in the artery walls and it causes narrowing and blockages. Okay. And then the HDL is kind of like the protective, which carries the LDL away from the artery walls for breakdown. So that's really helpful. And then triglycerides is another component of lipids. And that basically, it stores excess fat from our diet. That primarily comes from our diet, triglycerides. And increase of triglycerides actually also increases your risk substantially for heart disease. And so when we look at a lipid panel, a regular lipid panel, we get the HDL, LDL, and triglycerides. But we kind of miss a genetic risk, right? So when you talk about advanced lipid profiles, we're talking about ApoB levels. So ApoB is a type of cholesterol molecule that also contributes to the transport of cholesterol, and it's very similar to LDL. And so having high ApoB actually is also very dangerous. And actually, it's very similar to having elevated LDL and elevated LP little a. And I'll talk about LP little a in more specific because this is kind of known as the most strongest known genetic risk factor. And South Asians have a very high levels of this in general. So 1 in 5 South Asians will have an elevated LP little a. And this is typically not tested in a lipid panel, right? So sometimes you have to ask for it. You have to have a physician that knows to order it in certain risk factor groups. But elevated LP little a increases your risk for heart disease, strokes, and valve disease. And less than 1% have ever gotten this checked in the general population. And so that's kind of alarming. So I think 1 in 5 have elevated levels. Approximately 25% of South Asians have elevated LPA. Confers a 2 to 3 times risk of heart disease, similar to that of the established risk factors. And you only need to check it once. So this is kind of genetic. This is not influenced by diet or exercise. Whereas LDL and HDL and your triglycerides are. So that's kind of a distinction point. So this is just something you're born with. There's now like research on that show, hey, we have actually some medications that can reduce LP little a, but they're still in the pipeline. There's treatment options for them, and that's really exciting for me as a preventive cardiologist because if I see someone in my practice that's South Asian that has a LP little a that's elevated, I can actually direct them to these therapies that have been shown to reduce LP little a. So that's pretty exciting in the preventative cardiology world.
And sorry to butt in, but we actually had a question about that early doors as well. Is that something you would recommend that all South Asians are screened for? And why do you think it's not necessarily routinely checked?
Yeah, absolutely. I check in all my South Asian patients just because I am familiar with the test and I know that there's a genetic component to it. And I think the reason why it's not routinely checked is because most are just not aware of it. I think, and if they are aware of it, they don't know what to do with that information. And so I think it takes a specialist or a cardiologist that deals with this cardiometabolic scenario and lipids on a daily basis to kind of have that knowledge and expertise on like, hey, how do we incorporate this? Because again, we don't want to take this number as a solo number, right? We really incorporate this in total and in combination with everything else, your risk factors, your family history, whether you have other risk factors, high blood pressure, your other lipid panels. So I think in short, I think that's kind of the limitation. I wish that more people checked it, but it's just not part of the standard panel.
There was another question. I forget the name of the certain nutrient in garlic. I know it's not a major lipid, but we used to think like garlic was actually going to be helpful for LDL lowering. That's kind of, and it's not really a big lever, but like it's not going to work to any major extent, is it?
Yeah, no, I don't think there's that much like data on that. I think it's more the properties of the garlic is more like maybe anti-inflammatory. And so that is what actually may contribute to, lowering your overall like inflammation risk. And I don't think it directly correlates with, or there's not been any studies of it affecting LDL or cholesterol.
There has been a little bit on, it's a compound called allicin.
Allyson, okay.
Again, I don't know how significant the benefit is, and it's
Yeah.
probably not a major thing there, but still could
Right.
be. Like it's still
Yeah, yeah. I mean, there's definitely certain foods and groups like fiber. I think fiber is essential in helping with the lipid levels. And so including more of that, omega 3s, fatty acids, things like that can actually overall help improve your metabolic profile. So there's certain definitely foods, but then we have medications as well. But we tend to not start the medications unless we absolutely need to.
as
Yeah.
much like this is, as I said, I could sit here for the next 5 hours and speak about
Oh,
this.
yeah.
We do want to give a little bit of a rundown of the KMEDS program.
Good.
Um, so unfortunately, let's as much as we
Yeah,
want to
yeah,
go through all of
for
this.
sure. So let's do that. So basically, I want to kind of introduce KMED. So the reason why I kind of wanted to launch this with KMAC Fitness was because, again, KMAC Fitness is doing an amazing job at really helping us develop these healthy habits and really transforming our health. But I actually knowing numbers and using biomarkers to actually optimize our fitness journeys can actually go a long way. So we kind of want to really redefine the way we approach fitness transformation journeys because we have so much, data and numbers that we have to our disposal to use and to kind of optimize and really precisely give you the best outcome. So it's really a one-of-a-kind program that really combines the expert fitness coaching that the coaches provide with heart health focused lifestyle guidance. So all these things that I talked about in terms of optimizing your diet, optimizing your exercise to really help reduce your overall risk, specifically for the South Asian community. And I thought overall this was lacking in the fitness world. I don't see any other program kind of implementing this kind of approach to really tackle the unique health challenges where we in a combination of personalized workout regimens, really culturally tailored nutrition plans, medical insights using specific lab biomarkers to really optimize your journey. And so it basically provides a holistic approach to your physical transformations because I think it's great to kind of see physical transformation and seeing the actual benefits of it, but actually looking at your numbers and looking at, hey, how did my physical transformation actually help me get healthier, right? So this comprehensive action plan, you have a heart health coach that is kind of your champion, your guide to kind of help you and your personal trainer that produces a plan that is personalized to your lifestyle and health goals. And the main point of this is to really educate you, just like this call is doing in terms of your risk of heart disease, overall health, and empower you to kind of take charge of your health and know your risk, right? Because a lot of us may not go to a doctor. We may go once a year, and that visit is very just it's not very long. It's not comprehensive, and this is really to aim to kind of achieve your fitness goals while prioritizing your heart health. And so the way kind of it works is step one, you get your blood work, right? So I think this is the fact that you get an at-home testing kit to really give us data-driven insights into your health. And then you have a consult with me where we really go deep dive and do a comprehensive health assessment to review all your biomarkers, track your progress, uncover what's really affecting your energy, your metabolism, your performance, and then creating a personalized plan with your coach. So, this is unique in the sense of I would be communicating directly with your coach to kind of personalize a plan that aligns with your biology and your risk profile, and really implement these preventative measures early on, so we can really achieve not just a physical transformation, but a really overall health transformation. And so, the difference is, when it comes to your annual visit with your physician in primary care, which I think you should still continue to do. This is not to replace that. This is just to kind of enhance that. So, the depth of blood work, we would go beyond the basic lipid profile and basic metabolic profile that your physician would go, to really do advanced testing that's specific to cardiometabolic health. And we specifically look for hidden red flags early on and address them early on. So a lot of different biomarkers that affect your thyroid level, your liver health, your kidney health, your inflammation, energy levels, immune system, all that. And then the time and personalization. So most primary care visits last 10 to 15 minutes. The focus really is on immediate concerns, prescriptions, meeting insurance checkboxes, oftentimes. And so whereas KMED, where we differ is we really do a deep dive and you integrate your medical history with the fitness and nutrition plan that your coach gave into one actionable plan. And then really, this is like a really good integration of it. So, being a physician and also cardiologist that has gone through KMAC Fitness myself, I've been through their journey, and I know the struggle. And so, with KMED, you're getting a physician that works closely in collaboration with your trainer, to really align with your health goals. And then really, again, focusing on prevention versus reactive. Your annual visit usually is reactive. Problems are flagged only when labs are abnormal or when symptoms appear. This is really taking it a step further, like precision prevention and identifying risk early on. And the goal is just to optimize your health and not just treat, disease. And then accountability. I think the accountability that the coaches offer is amazing. But I think with this program, you also get a health coach and a physician on board to really look at your biomarkers and see how we can kind of reduce your risk overall and work together as a team. This is going to be a team-based approach, to really integrate everything and make it more of a health transformation. So that's kind of the specific. There's again, like these are the key differentiators. You'd get a lot more biomarkers annually. You get a lot more time with a physician. I directly tie in with KMAC Fitness, your macros and lifestyle coaching. This is not to replace your coach, but this is to really help them guide them, right? If there's certain biomarkers that I feel that may be affecting your training or your recovery or your sleep, things like that, I can actually communicate that with the coach. And I think that can make a really better outcome and a result and just experience moving forward. And again, this is not like a one size fits all. It's guided by your biomarkers, and really we program it off your physiology. And I kind of wanted to share. I talked about the risk profile scenario that I usually do for my patients. This is something I did for myself before I did my transformation. So I put all my numbers and all my data into one calculator that we use as cardiologists. And before my transformation, I was at a 21% risk of having a heart attack and stroke up to the age of 80. And I actually had an elevated LP little a, and that actually jumped about 10%. So just knowing that, I think knowing this early on in my journey really kicked me in gear in terms of like, okay, I know these numbers. Now I actually have data and numbers to prove it, and after my transformation, after, I measured my visceral fat levels, my LDL cholesterol actually reduced, my risk substantially decreased to about 2.3%. So this was very, very encouraging for me. And this is, I think, data that is really helpful and valuable while you're going through a transformation.
No, absolutely amazing. 100%. You had unreal results, not just for the photo shoot, but health wise as well. I suppose you're kind of like the first case study in KMEDs as well with those results. But yeah, if anyone was interested based on that presentation there or had any questions, by all means, go ahead, reach out to us or Amar afterwards. And yeah, we're running a little bit late on time. It's been amazing to hear from you and learn a lot as well. I hope that is the case for everyone who did come along and visit. And then you've just gone ahead and dropped the link for anyone who is interested in the chat as well. So, like I say, appreciate everyone coming along. If you do go ahead and share the screen, you'll be in with a chance of winning a free consultation, I believe it is. Go ahead and confirm that for me in just a second. But tag me, Dee, or David alongside, of course, K-Mac and Amar, and we will get you entered in with a chance next week.
Awesome. Thank you so much, guys.
I appreciate your time, man.